Giovanna. Good afternoon, everybody. It's a great pleasure to welcome you to the second episode of our webinar. Today, we will have a distinguished speaker, Giovanna Cenacchi, Professor of Pathology at the Biomedical and Neuromotor Science Department of Alma Mater University of Bologna. Giovanna has a long-standing experience in the analysis and interpretation and description of many myopathies, many disorders, she will today talk about basic techniques, basic studies of the electron microscopy, and she will show also a lot of images of different myopathies and stress the importance of this technique for our field. Thank you, Giovanna. Welcome, and the floor is yours for the presentation.
Okay. Thank you, Eduardo, to the organization of this webinar. And I would like to speak about the role of the electron microscopy analysis in the diagnosis of myopathies. Electron microscopy is now considered is considered an old technique in this period, which is also known as molecular era. Genetic era, in which the diagnosis is made by the use of genetic techniques. So it's not very often important to use muscle biopsy and to use this kind of technique. But I think that in some disorder, it's still important. So electron microscopy has utility, but I would like also to show you what could be the limitation in the use of this microscope. So the workup for the muscle myopathy diagnosis was in the past based mainly on the study of muscle biopsy, and also obviously after a relation with clinical data and so on. But now we can see that muscle biopsy is important only practically at the end of the workup. But I think that we can consider the workup in the diagnosis of neuromuscular disease must be considered as an integrated workout. So it's very important to join the clinical feature, such as anamnestic data, strength deficits, muscle fatigue, muscle mass variation, such as hypertrophy, atrophy, pseudo-hypertrophy, myalgia, and so on. And also to look at the lab tests, such as CK, LDH, aldolase, and assay for lactic acid, ischemic or aerobic. So it's very important to have all these data to start the workup for diagnosis, and also data coming from electromyography, which is known to have a very high sensitivity, but not a very high specificity. So in some cases, it is absolutely important to have muscle biopsy and to apply the technique we have already seen in the last webinar. So I don't want to go back. But during this technical approach to the study of muscle biopsy, we can look at the presence of this ultrastructural analysis, which is made by electron microscopy. We know that we have two different kinds of electron microscopes, the transmission electron microscope and the scanning electron microscope. The transmission electron microscope is an instrument which is useful to study the inner organization of cell and tissues, instead of scanning electron microscope is useful to study the surface of cell and tissues. This is an example of the modern transmission electron microscope in which we can make a comparison with a light microscope. Obviously, is a big instrument. On the head of this column, there is a production of electrons. So there is an electron gun. Then we can have an electron beam going down, interacting with the sample, which is here in this position. And then there is an interaction between electrons and sample. And after reaction, we can form an image on this screen, which is a fluorinated screen. So to have at the end an image obtained with pixel on the screen, and we see that we can have only black and white images because is given by the interaction between electrons. Electrons from electron gun, electron beam, and electrons constituting the cell and tissues. So the mechanism is a little bit complicated. We don't want to go into the explanation, but I think that it's very important to know what is electron microscopy. So we have a beam of electron used to create an image of a sample and can view sample at higher magnification than light microscopes and giving better resolution. So these are very important things, magnification and resolution, because we know that also with the light microscope, we can have magnification up to 1,000 times, but the resolution is not so high. Resolution means the minimal distance between 2 points, which can be observed completely distinct. So it's very important to have high resolution, to see object, to see cell and structure, even if the magnification is low. So we can have low magnification, but with a very high resolution power. So in this way, we can have smaller objects can be seen in a finer detail. So why electrons instead of light? Because at light microscope, we can have a magnification only up to 1,000 times and a resolution of 200 nanometer. Instead of with the electron microscope, we can have a magnification 450,000 times with a resolution of 0.5 to 4 nanometers. So due to these features, transmission electron microscopy is used to view the internal ultrastructure of cell and tissues. We have a beam of electrons which passes through an ultrathin sample less than 100 nanometer, interacting with it. And at the end, in the bottom of the column, an image is formed from the interaction of the electrons with the sample. Image can be viewed on the fluorescent screen of the transmission electron microscope or on a computer screen, as you can see here on the right in the slide. The preparation, the processing of the sample is not so simple as for light microscopy, even if the steps are quite the same. So at the beginning of the processing, we can have a fixation, but in this case, a fixation must be done with the glutaraldehyde, which is an aldehyde like formalin, but having two reactive groups, chemical groups, because glutaraldehyde must fix very well the tissues to see all the structure, all the organelle in the cell. Glutaraldehyde fix protein and stabilize the structure. After this first fixation, we have a second fixation using osmium tetroxide, which is a metal which is able to stabilize lipids. So in this way, with this double fixation, we can fix all cells which are organized with a lot of membrane, and membrane are constituted by protein and lipids. So in this way, using the two fixatives, we are able to fix very well all the membrane, so all the organelles in the cells. Then, to fix with the glutaraldehyde, we must have a very small sample, in this case, a very small muscle sample, because the molecule of a glutaraldehyde is bigger than formalin. So we can have a smaller sample to fix all the depth of the sample. Then after fixation, we must have dehydration, because we have water in the tissue, and we have to substitute all the water in the tissue with the fixative. And at the end, after dehydration with alcohol or acetone, for example, we have to use an embedding medium. The embedding medium is not paraffin as in light microscopy, but it is constituted by a plastic resin, because plastic resin after polymerization became very hard, but at the same time is hard and elastic to allow us to obtain thin sections. Before, thin section with a thickness of about 70 nanometer, we can obtain semi-thin section with a thickness of about 1 micron. So the semi-thin section are used to see with the light microscope the organization, the general organization of the tissue. These thick sections are usually stained with only one monochromatic stain, which is toluidine blue, because these plastic resin are absolutely hydrophobic material. So it's not possible to use the same stain which are used for light microscope. Then at the end, we obtain this final product with very small pieces of the biopsy staining in black due to the fixation with osmium tetroxide. Then we have to use an ultramicrotome, not a simple microtome, but ultramicrotome, which is a little bit more complicated than a normal microtome used in histology, to obtain this very thin section. The color of this section is like light yellow, practically silver stain, because this staining corresponds to the thickness of about 60 to 70 nanometer in thickness. Then at the end, we have to collect these sections which are floating in the water with a grid. The grid can be of different substances. Generally, they are copper or silver or gold, depending what kind of methodology we want to apply after, because, for example, we can also apply immunocytochemistry techniques, so to localize some specific antigen in the section. So in this case, we must use a gold grid, because gold is not reactive with the chemical agent used in these techniques. So after we have obtained the thin sections, we go to stain. The term is not completely correct. We must speak about counter stain, because you must increase the presence of heavy metal, which are able to have a strong interaction with electron. So to have at the end of the process a counter stained section with a lot of black and white and a gray scale to see all the features of the cell and tissue. So at the end, we can go after this last step using a solution with uranyl acetate or lead citrate, we have a final product, which is a section, very thin section, collecting on the grid. We can put the grid into the column of the microscope, and we can go to see the product with this instrument. This table summarizes the most important differences between light microscopy and transmission electron microscopy. On the right, you can see also the feature obtaining with the scanning electron microscopy, but is not the topic of this webinar. So we have to look at the resolution power, which is very, very different. So 200 to 500 nanometer in light microscope, and 0.2 to 1 in transmission electron microscope. And the difference is also between the maximum magnification. But as you can see, we can have also, using transmission electron microscopy, low magnification. But the most important feature is that even at this low magnification, we can have very high resolution of the particle we are observing. So we have light as a gun and electrons in the microscope, and the propagation medium is air in the light, and vacuum, very high vacuum, allow the electrons run from the top of the column to the bottom of the column of the microscope. And then obviously the lenses are different, because in light microscopy, as you know, the lenses are glass made. In the electron microscope, we can have electromagnetic lenses because we have electrons, particles such as electrons. The procedure to prepare the process, the sample, are very easy for light microscopy. They are a little bit more difficult for transmission electron microscopy, mainly related to the step of cutting, because it's not easy to obtain very thin sections. So what about the role of electron microscopy? Electron microscopy plays a vital role in unraveling the ultrastructural features of normal and pathological alteration of different subcellular structures in cell and tissues in response to change in the microenvironment. Obviously, in this contemporary era of molecular diagnostic testing, the use of minimally invasive genetic testing and non-invasive biomarker approach is chosen over, obviously, invasive skeletal muscle biopsy in our field. Nevertheless, skeletal muscle biopsy remain an important investigative tool in the diagnosis of different groups of muscle disorder. And mainly, I think that electron microscopy of muscle offers insight into the pathophysiological mechanism, and in some instances can guide, secondly, molecular genetic analysis, so limiting the field in which we have to search for genetic alterations. So what are exactly the role of electron microscopy? Electron microscopy serves as a confirmatory tool, mainly in some rare forms of congenital myopathies, such as cylindrical spiral myopathy, zebra body myopathy, fingerprint body myopathy, or also intranuclear rod myopathy. And in some cases, not subjected to histochemical staining, it aids in offering definitive diagnosis in certain group of muscle disorder, such as previously congenital myopathies and metabolic myopathy, in particular mitochondrial myopathy, because we know that in the early step in development of mitochondrial myopathy, not in every case is possible to have positive reaction from the biochemical point of view to make a diagnosis of mitochondrial disease. Instead, with the application of electron microscopy, it's possible to see that there are alterations in the morphology, in the number, in the quantity of mitochondria in the muscle biopsy. So it's very important to make very early diagnosis. It's very important to make very early diagnosis, mainly in some lysosomal disease, such, for example, in glycogenosis, because we know that now we have enzyme replacement therapy. So it's very important to give to patient the correct drug, the correct therapy to avoid side effects due to the disease. So it's important to make very early precise diagnosis. Also, it's important to distinguish between a lot of different vacuolar myopathies due to the presence of different content in vacuoles in the muscle. The use of electron microscopy does not have a diagnostic implication, for example, in muscular dystrophies and neurogenic disorder, even if also in this case, in this kind of disease, is very often important to have a small piece of muscle biopsy prepared for electron microscopy to investigate what is the pathogenetic mechanism, because the identification of pathogenetic mechanism is absolutely important to allow to have a personalized therapy and to have new personalized and tailored therapy related to the exact enzyme, the exact protein, which is altered by gene mutation. But it's important to know what are the key molecular mechanisms in different kind of disease. So it's important to know what are the subcellular organelles which are involved and which must be considered key organelle, key target for the therapeutic approach. So we can have diagnostic in myopathology, and in this case, electron microscopy may be considered essential or only helpful, or at the end, wasteful. Wasteful, for example, mainly for dystrophic disease, even if in this case, electron microscopy maintains a role as investigation methods in myopathology. So I think that even if electron microscopy is not a routine diagnostic procedure, it's important as a routine practice to have a tiny bit of skeletal muscle fixed correctly in a 2.5% buffered glutaraldehyde soon after biopsy, which must be considered useful because we can go to observe the sample after, in a second time, when we think that is not enough what the information you have using the routine techniques and methods to analyze the biopsy. So some picture obtaining for muscle and muscle disease. In this case, on the top, on the left, you can have a mitochondrial disease, which we have altered mitochondria with this electron-dense round particle inside the matrix. Probably it is constituted by lipids, or we can have a lot of microcrystals, which might be considered the marker of mitochondrial disease. Then on the right, it's possible to see a nucleus with a glycogen inside the matrix, which is a consequence in the lysosomal storage disease, or a core, as you can see here, in which there is a derangement of architectural organization of myofibrils in the muscle, or the presence of tubular array, which can be considered specific for a specific kind of disease, tubular aggregate myopathies, but sometimes they can be also found unspecifically in other myopathic disease. Then you can have round, synconcentric laminated bodies, as you can see here, or spiral organized membrane which can be considered not specific for specific myopathy. Or that in this case, we can have cytoplasmic bodies, which are constituted by core, very electron-dense core, and a structure like a sun with rays peripherally located in the sarcoplasm of the cells, and also in many myopathy, we can have also a loss of myofibrils and disorganization of the architectural pattern. What about some congenital muscle dystrophies? As you can see here, we can have central core disease associated with RYR1 mutation. As you can see here, we have a streaming of the Z line, completely disarrayed muscle fiber with disorganization of the myofibrils, as you can see here. And also there is an absence of cross striation of the myofibrils. Or on the right, it's possible to see rods, which are, we must consider specific for nemaline myopathy, but we have found these rods also related in some glycogenosis, for example. So it's very important to go to this interdisciplinary approach to make diagnosis. So it's very important to know the clinical features and also the other data obtained for routine preparation by muscle biopsy to make a final diagnosis, because is not the only feature to find rods to make the diagnosis of nemaline myopathy. So it is very important clue to know. What about myofibrillar myopathies? So we use generally an immunohistochemistry panel for myofibrillar myopathy to see if there are aggregates in the cell related to different proteins, such as in this example, the presence of aggregate of desmin, but we can have also aggregate of myothelin or alpha-beta crystalline or filamin C. The electron microscopy show different morphology for this aggregated depending on the protein constituting the filaments. So in this case, we can have this electron-dense material, which is tightly related to filaments, which are derived from cytoskeletal filaments constituted by desmin, as in this case. So constituting this aggregate, which are positive for desmin with immunohistochemistry or immunofluorescence. And in another case, on the right, you can see the presence of granulofilamentous material, which is a little bit different from material derived from aggregation of desmin. So we don't have electron-dense material, as you can see, but probably the filaments are thinner, and so the organization are different from the previous one. And probably in this case, there is a reaction with the immunofluorescence technique with the presence of myothelin. So what about storage disease? Storage disease represents a big chapter of the pathology, generally speaking, involving the central nervous system and also the peripheral nervous system, because in some cases we can have an involvement, for example, of the brain. And in many cases, they represent pathology which are not treatable. Only recently, we have some specific therapeutic approach to specific lysosomal disease. Lysosomal disease are more than 70 in type. They can be lysosomal or not lysosomal storage disease. They are genetic disease, generally with autosomal recessive inheritance. The pathogenetic mechanism is not ever fully understood. And we can have a severe and progressive neurological involvement, mainly when we have involvement of the brain. And not very often systemic disease are associated with hepatosplenomegaly, for example, or corneal opacity and bone dystrophy. We have a lot of enzymes, as you can see here, which are related to lysosome. So we can have enzymes which are in the middle of the matrix of lysosome, or they can be enzyme protein which are located on the membrane of the lysosome. So we have a lot of disease involving lysosomes, involving protein inside the matrix or protein which are localized at the membrane. An example of this disease is represented by neuronal ceroid lipofuscinosis, which are clinically stratified by their causative gene mutation, and their etiological diversity appear to converge upon a spectrum of common clinical phenotype. It is therefore likely that molecular origin underpinning the individual neuronal ceroid lipofuscinosis also converge upon common pathological cascade. In this kind of disease, we can have a different organelle involvement in the cell. For example, we can have involvement on lysosome, or we can have a mitochondrial dysfunction, or also we can have endoplasmic reticulum alteration, or we can have, in specific disease, endolysosomal trafficking. We have a lot of disease. I don't want to go into the particular case, but I would like only to remind you that we can have specific morphology of the deposition, of the accumulation of this ceroid lipofuscinosis, which appear as granular osmophilic deposits, for example, in CLN1, CLN10, and many other, or the presence of a curvilinear profile, for example, in CLN2, or the presence of fingerprint profile in CLN3, or in the other one, as you can see here, 5, 6, 8, and muscle D8 and CLN8, we have in both late infantile or infantile or adult variant, we can have mixed type of inclusion. So it's important to look at electron microscopy, what is the morphology of the material which is accumulated in the lysosome or outside the lysosome, involving different organelles in the cells, to allow clinician to ask for specific genetic analysis, but the role of electron microscopy is to suggest, to indicate what kind of disease it probably is. Because and also it's very important also to clarify what is the pathogenetic mechanism. These are two clear examples. So ceroid lipofuscinosis 1, we can have GRODS, so granulars, material, electron dense. As you can see here, there are very small granules which are represented into the lysosome, as you can see here. Or here we can have the presence of curvilinear bodies, which are very different from the previous one, and they are feature of the CLN2. So it's important to do electron microscopy in this case to guide the next molecular testing, genetic testing, to make a final diagnosis. Another important field in the storage disease is represented by the disorder of glycogen. We have a lot of disorders involving the metabolism and the catabolism of glycogen. This is a clear image obtained by a semithin section. So it is a 1 micron section seen by light microscopy, in which in cross section of myofibers is possible to see that there are accumulation of material the periphery of the cell, destroying quite completely the myofiber. So obviously, in this case, we can speak about storage disease. But when we go to electron microscopy, we can see that there is glycogen particle. Sometimes they are completely empty of the glycogen because it's a late step in the development of the disease. But this is the condition in the childhood. But we can have also cases in adult, as you can see here, in glycogenosis type 2. So in this case, we have hematocene is quite normal without the big vacuoles we have observed in the babies. And also with the oxidative enzyme, we don't see particular alteration in the cells, and this is a pass reaction, PS. But electron microscopy shows that there are some vacuoles, so they are lysosome vacuoles limited by membrane, with a content represented by a lot of glycogen particles, which are completely electron dense. It's very important to make diagnosis because I told you now we have enzyme replacement therapy. So it's important to make very early the diagnosis. Why? Because the deposition of this aggregate of glycogen are usually associated in the step after the first step. We can have also the association of autophagolysosomal vacuoles. So it is a negative marker for this disease, and we will see after. We have also different glycogenosis, like in this case, we have a type 5 glycogenosis associated with deficiency of phosphorylase. In fact, the enzyme reaction is completely negative, related compared with normal organization of myophosphorylase. And in this case, the glycogen granules are aggregate in a very large lake, which are localized under the sarcolemma, so not contained in the lysosome vacuole. So they are free in the sarcoplasm. Also in this case, we can see the position of glycogen associated with these big autophagosomal vacuoles. So it's very important because we are in this case in the last step in the development of the disease. As you can see here in glycogenosis type 2, as I told you before, we have big accumulation of lysosomal vacuoles containing glycogen, but they are also associated with these lysosomal vacuoles. So it's very important because autosomal vacuoles are related to destroy, to metabolize degenerated organelles. So in this case, they are not free to metabolize the enzyme replacement for therapy. So in this case, the therapy could be not efficient because we have glycogen, but we have a consumption of membrane due to the formation of these autosomal vacuoles, which are involved in the elaboration of degenerated organelle in the cell. So it's very important to make diagnosis very early. In the first time of the study of the glycogenosis, another disease like Danon disease has been considered as also another glycogen storage disease called 2B. But now is not really a glycogenosis, even if we can have a glycogen in the cells. But the disease is due to mutation in the gene codifying for a protein, which is lysosome associated membrane protein 2, so LAMP2, which is localized in the lysosomal membrane, and it is involved in the translocation of some degenerated organelles or substance present exogenous substance present in the cell, translocation in the vacuous matrix to digest. This disease is very important because there is also an involvement of heart with the development of hypertrophic cardiomyopathy. We have muscle weakness, and also we can have a mental retardation. It's important to make a differential diagnosis with this disease, mainly when we are speaking about muscle biopsy, obviously, but also for heart, because orthoglycogenosis type 2 are involving heart. So it's important to make diagnosis, to not apply the enzyme replacement therapy in the disease because it's another disease. And what is the difference? At light microscopy, we don't see specific differences because we have vacuoles, as you can see here. We have vacuoles also at the periphery of the myofibrillar compartment. We can have a PAS positivity because we can have glycogen deposition, but it's not glycogenosis. Why? Because even if we found glycogen particle aggregate, but we must look at the formation of these vacuoles, and at high magnification, it's possible to see that there is a basal membrane, basal lamina, which is here in the inner part of vacuoles, probably deriving from the surface sarcolemma. So there is a completely different origin for these vacuoles. It is important to look at the organization and the morphology of these vacuoles to make the difference, because we see also in this case the presence of glycogen aggregates. So do not mistake with glycogenosis, for example, type 2 maltase. As you can see here, we can have autosomal vacuoles, as you can see here, big, and also the vacuoles with basal lamina inside. So this feature allow us to make a final specific diagnosis. So glycogen appear usually as a granular, with a granular morphology, but not in all glycogenosis, because we can have example of glycogen storage disease 4, in which we can have a deposition of a different morphology of glycogen. So in this case, we can have fibrillar glycogen, which is seen in this type 4 glycogenosis, because we have in this disease a defects in glycogen branching, and so we can have a polyglucosan myopathy, in which we have a different kind of deposits and vacuoles. As you can see here, we don't have granules, but we have very thin filaments, which constitutes the inner part of these vacuoles, not limited by a membrane, like what we can see, for example, in the Lafora disease, which is a neurological disease. Going to another chapter of the myopathies, we can look at metabolic myopathies involving mitochondria. And I can see the presence of crystalline structure in the mitochondria, so deranging the normal morphology of the mitochondria. And this is not early step in the modification of mitochondria, but it represents probably one of the last steps in developing the disease. But we can have not only the presence of crystalline structure into the mitochondria to make the hypothesis of a mitochondrial disease, because sometimes we can see, for example, as in this case, which is a baby muscle biopsy, in which we can have a very strange mitochondria, swollen, with a loss of inner matrix, with the presence of fragmented cristae, and these are not absolutely, they are not normal. But in this case, we cannot have the biochemical diagnosis of mitochondrial myopathy. We can also suggest to neurologists, to clinicians, that it's necessary to look at genetic for mitochondrial disease, because the presence of this kind of morphology of mitochondria is absolutely not normal for baby muscle biopsy. Another chapter is represented by the diagnosis of idiopathic inflammatory myopathies. Obviously, you know that in this case, we can have a lot of antibodies, serum antibodies to make diagnosis, but in some cases, it's important also to look at muscle biopsy. Not only to make or to confirm the diagnosis, but in some cases also to identify what is the pathogenetic mechanism, because now, even if these pathologies are commonly treated with routine drugs such as steroids or immunoglobulin, for example, but now we have a specific drug to treat some of these inflammatory myopathies. Here there is the main classification of the disease, but I would like to focus your attention with, for example, with the use of JAK inhibiting therapeutic approach, for example, which is now used. It is a monoclonal antibody, which is tested in adult patients with dermatomyositis. So it was that time very important to define what is the pathogenetic mechanism in this disease. In fact, here we have a patient with dermatomyositis, with erythematous skin appearance and the presence of papules and nodules, Gottron nodules, and the biopsy show the perifascicular atrophy, as you can see here. But this atrophy is not a neurogenic atrophy, obviously, but is given by alteration of capillary structure, which probably they are infected by hypothetic viral infections, and there are degeneration in these endothelial cells of capillary. So there are a multi-layered basal lamina, and as you can see here, there is a thickness of the capillary wall. There is also increased of positive vessel for alkaline phosphatase, and obviously the diagnosis has been made by staining for a specific complement factor. But electron microscopy, what is able to do is able to study endothelial cells. So we have in the past a case of children with a dermatomyositis, which is rare in children, and there weren't the specific marker to make a clinical diagnosis, but after biopsy, we have seen in the endothelial cell cytoplasm that there were these tubulo-reticular structures. They are important because they are due to synthesis of a lot of interferon gamma. In fact, now we know that we have some monoclonal antibodies against this interferon to cure this kind of patient. Another kind of inflammatory myopathies is given by sporadic inclusion body myositis, which is considered the most common progressive muscle disease for older person than 50 years. It leads to severe disability, and there is no enduring treatment currently available, as you know. The hematoxylin eosin show a lot, not every vacuoles, but sometimes there aren't in the hematoxylin eosin, as in this case. We have rimmed vacuoles, as you can see here, with a rim staining with hematoxylin due to the presence of a lot of protein. And then we have these vacuoles also in the gomori, And also there is a presence of COX negative fibers. There is a positivity also for TDP43, and the presence of deposition of TDP43 is very interesting because is a common features with neurodegenerative disease of central nervous system, such as Alzheimer's disease, for example, or for amyotrophic lateral sclerosis, for example. In fact, these diseases are also known as neurodegeneration of the muscle. And why? Because we have in the cells, in this kind of disease, the presence of aggregates of filaments, which are represented inside the nucleus, as you can see here. We can have also tubular structure aggregation in the nucleus. And we have a lot of very big autosomic vacuoles, and in which you can observe a lot of myelinoid lamellar membrane, as you can see here, together with the filaments and also debris of cell organelles, as you can see here and here, together with filament in the nucleus and filaments also in the sarcoplasm. And the presence in the nucleus must be considered as the marker to make final diagnosis of this disease. So it's very important. And these filaments are constituted by a lot of different proteins, such as TDP43 or alpha-beta crystalline, or also we can have amyloid, for example. So to make this disease very similar to neurodegenerative disease. Only a few words about muscle dystrophies, because I told you that it is not important the use of electron microscopy to make diagnosis. They are a lot now, but not for every of these diseases. We know the exact pathogenetic mechanism. So it's very important to use electron microscopy to understand what are the organelles which are involved as a key organelles in the muscle cell, to understand what could be the molecular mechanism, and also to make a specific therapeutic approach. For example, in Duchenne muscle dystrophy, we know that the most important feature is represented by the absence of dystrophin and the fibrous adipose substitution of muscle. Electron microscopy is not specific. In fact, it's possible to see degeneration, a specific degeneration of a cell, but we know that there are a lot of different symptoms which are related to dystrophy. So in this case, we know that we have a different way to restore dystrophin, and it is very important to know what are the different mechanisms to apply different therapy, which can be considered symptomatic therapy, so probably not completely curing the disease. Another important field is related to dysferlin-related dystrophies. We have alteration unspecific for in hematoxin eosin, the presence of coiled fiber in Gomori reaction, and atrophic fibers in Gomori staining. And electron microscopy show the generation of muscle with a loss of myofibrils. Obviously, there is a loss of positivity for dysferlin, as you can see here, compared to normal organization with immunofluorescence. But the electron microscopy, what showed the presence of a lot of very small vacuoles, vesicles, which are located beneath the sarcolemma. Why? Because probably these small vacuoles are needed to restore, to regenerate the sarcolemma, which can be broken during the normal physiological exercise, physical exercise. But the absence, the loss of dysferlin here impede the binding between this small vesicle with the membrane, because in this case so constituting a sort of biological band-aid, as you can see here. So what are, after the study of this Ferlin-related dystrophy, limb-girdle muscle disease, is that this Ferlinopathy was characterized by a very active inflammatory degenerative process, possibly associated with an efficient repair and regenerative system. So it was very important to know what is the mechanism. About the fukutin-related protein, limb-girdle disease, fukutin-related protein is a putative glycosyl transferase, which is involved in alpha-dystroglycan processing, so giving an alteration of the membrane and basal lamina in the muscle. So what we can see in this kind of patient, hematoxylin eosin is not so specific for this disease, because we can have a different picture with different grade of severity, but electron microscopy show the absence of the membrane. There are a lot of breaks at the periphery of the cell, so it is must be considered a specific sign of the disease, so to involve the going deep into the definition of the pathogenetic mechanism. Last field is represented by limb-girdle muscle disease D2, transplantation related. This is very rare disease, autosomal dominant, with giving a progressive muscle atrophy. There is a very high variability in clinical symptoms. The disease is given by mutation in the gene of transportin 3. And the structure, the electron microscopy show specific alterations, because the hematoxylin eosin showed only that there is atrophy, degeneration, the acid phosphatase positivity in the cells, probably also positivity for P62, and the position of aggregate of desmin and myotilin, but is not enough to define the disease. In fact, here we have the electron microscopy show completely disarrangement of myofibril architecture, alteration in the morphology of the nuclei, which appear as electron-dense chromaty at the periphery of the nucleus, then aggregation of mitochondria with a crystal. Probably they represent a secondary alteration due to the alteration of the general structure of the cell. But mainly we can see that there is a very strong disarray in the organization of myofibril, as you can see here. And also we can see aggregation of filaments, probably deriving from cytoskeletal filaments, or also from filaments of the myofibrils. After the definition of the gene involved in the pathogenetic mechanism of this disease, we make an hypothesis in which transportin 3, which is useful to translocate factors, splicing factor from cytoplasm to the nucleus, probably there is an alteration in the differentiation of the cells. And in this case, at the end, there is an alteration in the distribution of cytoskeletal filaments, so giving also formation of activation, autophagy, presence of vacuoles, autophagic vacuoles, so giving at the end an altered myogenesis. So what we have done, we perform experimental animal model using zebrafish. We induce the disease development, injecting with transportin 3 mutated protein. And what we have seen at the end of the development of the embryo is that we can see with electron microscopy the quite same alteration we have seen in the human muscle biopsy. As you can see here, we can have this disarrangement, disarray, severe disarray of the myofibrils, as you can see here in the human, as you can see here, dislocation and perpendicular array of the myofibrils, and also some alteration in mitochondria, as you can see here, swollen with tubular aspect, tubular morphology of the crystal. So it was very important to define what is the pathogenetic mechanism of the disease, because we think that in the future we can develop new therapy to cure this disease. So in conclusion, I would like to tell you that electron microscopy is an old technique because it has been developed in the 19th century, about in the 1940 years, 1960 year, to understand the ultrastructure of all cell and tissue, and to define what are the pathological alterations in the main important disease of the human using muscle biopsy. But now, even we are in the molecular era, so it's important to go to genetic testing to make a final diagnosis. The electron microscopy still maintain an important role in the diagnosis of some disease, to confirm some diagnosis in specific disease, but mainly I think it's very important to understand what is the pathogenetic mechanism of some myopathies for the future definition of a new therapeutic approach to cure this patient. So I'm finished and I conclude, and I thank you very much for your attention.
Thank you very much, Giovanna. This was fantastic, not only for the images that you showed that are really beautiful to see, but it's very important to outline for me the continuum that we have in myopathology between the diagnosis, the research, and the comprehension of the mechanism of disease. So it's sometimes very hard to understand to other colleagues how the basis of the diagnosis is also the basis to do research and to comprehend this disorder and possibly go into therapies. So I don't know if there are questions from the audience. I've seen that there were 58 participants. Please go ahead if you have any question. Everything. So there is a question from Lola Lessard. How well translate the changes observed with the EM in animal models to human?
How is the role in animal?
So from the translation of the
Okay.
of the change observed in
Yes.
the human, how do they are respected or reproduced in
Yes,
animal
yes.
models?
We collaborated with a veterinary medical doctor, study some dystrophies in some bovine, cow, in some different big animal, and to see if the mechanism the same. So we study with the electron microscopy because the techniques routinely used in the field of veterinary are not the same used for human biopsy. So in this case, it's important to study the animal biopsy, to study pathology. And I also, speaking about the modeling of the in vitro model, we can use an in vitro cell model, but I think that is very important to use small animal like zebrafish, because it have genes which are quite similar to human genes. So we can create a model reproducing our disease. So it's very important mainly to understand what is the pathogenetic mechanism. But I think that in the future it's very important also to test drugs because avoiding to use big animals. So I think that it's important to use this model, for example, or Drosophila insect or zebrafish.
Very good. I have a question. Now we are using more and more 3D muscle models. Do you know or can you tell us something about new techniques that using electron microscopy help reconstruct the 3D structure of the muscle and could let understand us better how the lesions are localized and how they are formed?
Yes. I think that now, in a different way from 2D culture, cell culture, it's possible to have a 3D model in which we can recreate a microenvironment, which is more and more similar to physiological environment we have in the human. And I think that this 3D model can be used more in the future to study the mechanism, because we can have interaction between cells and environment. So to study also the relationship between signals coming from the environment and the response from the cells. So I think that in the 3D model, cell model, I think that in the future they will be the most important model to study the pathogenetic mechanism and to study the therapeutic effect of the new drug.
Okay, thank you very much. There are my person thanking for the excellent overview. I don't think we have any new question. So I will close the session for today. Thank you again, Giovanna. And
Thank you to you.
let's meet next week for the third episode that will be about the metabolic myopathies with lipid disorders and polyglucosan storage myopathies. Thank you very much.
Okay. Thank you to
Bye-bye.
you and to the audience. Bye-bye.
Ciao.
Bye.